Welcome to the Aesthetics Mastery Show. I'm Dr. Tim Pearce.
Hi, I'm Miranda Pearce.
And we're joined today by, as my 4-year-old calls her, the peeled lady. That's because we're going deep on injection technique, what it is that holds clinicians back and what you can do when you understand the components of great injection technique and the principles you can apply to create better and safer results for your patients.
So what are the foundations that make up good injection technique?
So injection technique starts with knowing the purpose of your injection. And that sounds obvious, but it's something you learn when you start training people. And I love seeing really good injectors going into a training environment and they suddenly have to justify everything that they're doing. And it actually pulls apart your reasons for why you do what you do. And sometimes you have to change them because you realize you're only doing them for idiosyncratic reasons rather than for a purpose. And there's a great book, which I've forgotten the name of, which talks about how you should start every action with being really clear on the outcome that you want. And for a good injection technique, there's an aesthetic result and there's a minimization of complications. And it's those two things that then flow on to help you design the rest of your technique. So you know what the aesthetic difference is. So it might be, for example, I want definition on the vermilion border. And you then know the complication risk you don't want to have, which is I don't want unnecessary bruising and I don't want to occlude the superior labial artery. And if those are your two driving forces, you might also throw in there, I don't want to cause unnecessary discomfort to the patient. So there might be 3 things that you have to then respect while you try and get the aesthetic result. And your position of the filler when you pull your needle out should be primarily achieving that aesthetic result. So you need to know a little bit about the 3 dimensions of the structure you're injecting. No, not a little bit, a lot, in order to design a technique that balances all these things. And that's the key thing. It's a balancing force. You can't go too much into the aesthetic and you can't be too safe or you don't actually do any work. So it's a continuous process of balancing these forces, which is why it's endlessly tricky. Basically, you have to think about it very heavily and carefully or copy someone's technique who's done that for you.
And once you are clear on your aesthetic goal and you are aware of the kind of complications you might be able to create, how do you then decide which technique you use?
So the short answer is you train with someone that you really respect and you know they're clever and you kind of don't need to do all the thinking initially. But what I want everyone to get to is the point where you understand the rationale in detail for everything that you do. That's the best place to be in, because what you'll see happen with injectors is, and I've seen this so many times with people I've mentored, is that they learn all the injections to a really high standard, and then they go to their first conference and the first guy up on stage completely does it differently, and they go, oh my God, I'm wrong. I've been doing it wrong the whole time. He said 7 things that are different to how I've been doing it, and my whole world just fell apart. And that happens when you don't understand the rationale. So what I'm always trying to get injectors to do is to build that mental model, the roadmap, the justification for your injection technique is more important than your actual injection technique for becoming a wise injector, as opposed to just someone who replicates what other people do.
That's interesting, because part of me is thinking, oh yeah, I'm not a clinician myself, but I want to be a wise injector. Another part of me is thinking, there is something quite nice about a bit of paint by numbers action, isn't it? You feel secure and like someone else told you to do it and that they are really good. But like you say, you're on this constant hamster wheel of feeling not enough, because each new person that comes along, you aren't able to justify. You just have to feel like, oh, well, what was I doing all this time?
Well, every injector starts out that way. I mean, we start out in our training facility with people who've probably never injected a face before. I know before starting, I might have done a few lidocaine injections in A&E, but I hadn't really sculpted a face. Like, it's not part of normal injection practice. And I started out like most people, copying like word for word what the injector had shown me what to do and getting a result, and also knowing why they said that. There's a bit of justification, but what happens is as soon as you see someone do something differently, you realize you only know a very narrow sliver of the complexity of it. So I use this analogy a lot for new injectors, which is that it's the difference between a map and knowing where you're going or knowing your area. So if you think, for example, about what it's like if you've never been somewhere and someone's trying to direct you to the corner shop and they say, go 3 rows down, you'll see the pub on your left, turn right, and then the corner shop is 200 yards further from there. Most people can get there. But as soon as you start in a different place, you're immediately lost. And that's what happens with new injectors who've been taught one technique without the rationale. Is that as soon as some aspect changes, they're completely lost, and that's a horrible feeling. And they quite often will jump to the latest technique that they've been taught and say, well, that's my new technique for now, because they haven't yet formed the deeper rationale behind each angle, position, depth. But that takes time. You can do it quicker if you consciously go after it and search for the rationale for every injection. And that is the foundation of building your own technique that's robust against other people coming in with new ways of doing things, so that you're not just doing the newest technique, you're doing the best technique that fits with an overall kind of a wise understanding of the face. If you're not, and I know this from training people the first time, that the first thing is your anatomical resolution is much lower. And what that means is, if you picture, for example, injecting a nasolabial fold, when people first start, they do not see a big difference between, I mean, I don't know how well you can see it on camera, but if I'm going straight down right near the alar base versus an angle that's at 90 degrees to the nose towards the alar base versus one that's maybe slightly angled up, they all look the same to the novice injector. Whereas for me, that injection looks really dangerous because it's angled up towards what I know is underneath here is the infraorbital artery. And it's a little bit closer to also where the facial artery becomes the angular artery. So there are 2 big risk factors for that angle that are different to that angle. And that only comes from before each injection, getting the anatomy straight in your head and knowing the main things you don't want to hit. Now, this is quite obvious, really, if you imagine. So just imagine that you're walking along a cliff edge. I mean, if you can see the edge of the cliff, you don't need to be told, don't fall over the cliff. Like it's part of how you calculate your way of navigating. So the last thing you should always do before you inject, and I still to this day do this with every injection, is I'm picturing the dangerous things I don't want to hit, and that automatically informs your technique. So it starts with anatomy, and that continuously evolves because you keep on to add new layers to it. But that's the last thing that goes through my mind is, where are the arteries? Where they're likely to be running. You can palpate as well, which is a really useful thing to add to it. Often you can feel pulses in some of these areas. And then you ask yourself, how do I place the filler in such a way so that it doesn't risk blocking this blood vessel? That will, if you're thinking clearly enough, it will automatically shift some of your angles, because you're already thinking, as long as your anatomy is good, that if I go in at this angle, I'm getting closer and closer to the infraorbital artery and the facial artery, which is making it more and more dangerous. So that's something that might help, is just getting the key anatomy right last thing before you inject, and then modifying your technique accordingly. The other thing is, you've got to have a shift in your understanding of how you're actually modifying risk, because on the lower end of the spectrum, the simplistic understanding of risk is, if you do the injection and you successfully don't block a blood vessel, for example, and you successfully get a result, that therefore it was a safe injection. And that's actually not true, because what we're trying to do is picture the same injection given 100,000 times over your career and ask yourself, where's the most likely place for this artery and how do I avoid it on average? Because the chances are, if you're angled up just a few degrees, you're going to be a little bit closer to the density of where that artery is. If you imagine facial anatomy as overlaying all of your patients all together, so you take every one of their faces, like the map of their arteries, and stick one on top of the other until there's 100,000 of them, there'll be a density of artery over particular areas, and it won't be the thickness of one artery, it'll be 10 times thicker than that. So what we've got to do is try and choose a technique that's finding basically a very small, low risk area in the broader area, and try and always think about getting it there, because this is not just one technique, it's a pattern of behavior you're going to repeat for the rest of your career. And little shifts will modify risk in a way that makes you someone who gets an occlusion once every 20 years versus once every 3 years.
Fascinating idea. Almost like tracing paper, just laying them over on top of each other and then avoiding that area. What else would you do when you are getting ready to inject? So you said that you're already thinking about the mental model of the anatomy and thinking about how you can minimize risk. What else do you do?
Okay, so once you've got the mental model of the anatomy clear in your head. And that doesn't just mean the 2 dimensions, because that's where most injectors start. You start out with the picture from the textbook. The next thing is you've got to know the depth. So where is this artery I'm trying to avoid? Mostly, if it's coming out of a foramen, it's on the bone. Otherwise, they tend to be in the middle layer, in the fatty layer is most common, with some exceptions. So that's the next thing to know, your depth. So you've got the 2-dimensional and the 3-dimensional position. And then you need to start thinking about your technique. Now, you design your technique first in your head, which is I want to go in at this angle because I think over time that's more likely to keep me further away from the artery at this depth. And the next thing is going to be about how do you actually deliver that accurately, because there's no good knowing that you want to park in a particular parking spot if you're basically cack-handed and you don't know the car at all. It's the idea is only half of it. How are you going to execute this plan? And that comes from it actually starts with your feet. Often I see injectors battling with a new technique. They've often been injecting for years, but then they're taught a new technique and it throws them off balance from their feet. So you've got to start by being in a position where your feet are stable. You should be rooted to the ground. Half the time that makes people look more comfortable immediately. It's that kind of slanted on one angle or with most of your weight on through one side of your body that makes everything look unstable. And then you're trying to stabilize things in as many ways as possible. So feet are stable. I often will stabilize my pelvis against the bed. I'll then maybe lean my elbow against some other part of the bed or the patient's shoulder. It's quite good. And ultimately, the most control you have is when you're only having to worry about your fingers and maybe your wrist, but you're not trying to control your whole arm. Now you can so sometimes I will inject just using my arm, but I'm usually tightening it up against my body so that this is stable. I'm basically trying to shrink the amount of processing and stabilization I need to just the parts of my body that are much more finely coordinated, and that will give you the ultimate control. So now you've got a clear mental model of where you're trying to go, and then you're actually you're stabilized so that you've got that control, and then the next step is to do it like relatively decisively but slowly. So sometimes people, when they're nervous, they do this too quickly because they don't want to make the group wait and stuff like that. So the first thing I would say is just do this really slowly and then break it into components. So often each injection technique has several stages if you think about it, because you might go through the dermis and then change angle and then slide in all the way through there. Then you do your aspiration, then you check the patient's comfortable, then you do a small injection, watch their response, then you do the rest of it. But it's the stages are also one of the key things once you're ready to inject.
It's amazing hearing it talks about in this way, because obviously if I'm being injected or if I'm even just watching other injectors, they either just look like God's doing it or they look a bit awkward. But actually there's so much that goes into it, isn't there? If you break it down like this. And actually it scares me a bit because I'm thinking about, people who, let's just say, are less than worthy of injecting, just whacking it in. I suppose they probably have some kind of, I don't know, it's worrying.
That you can see there are injectors who don't have a clear mental model, and they're very easy to spot by someone who does have a clear mental model, because you see, I've seen a video of someone injecting jawlines, literally just going along. I'll show you on this model. Anatomy isn't quite right, but using a needle along the jawline, just basically piercing all the way down and bolusing along here, and right over here you've got the facial artery, and she might be lucky for 500 procedures, but eventually there's a really high chance you're going to hit the facial artery and block the whole blood supply to part of the face. And you'll see it on Instagram. If you Google some of the lower end clinics, you will actually see them carry out procedures that are terrifying for those of us with a good mental model. And yeah, it will. There are major complications do happen.
Yeah. And so coming back to this, so you've got yourself now, so you've, in your mental model, you've thought, how am I going to avoid complications? And you've been obviously careful with the anatomy. You've then sought to implement your strategy by getting stabilized, which I love. Because actually, from a mindset perspective, rooting yourself in the ground with your 2 feet and even just imagining yourself rooted to the ground can be very good for a mindset.
Absolutely. It's what I do. If someone's nervous on the first day of training, that's the first thing that makes them feel better, is actually get your legs stable, pelvis. All that makes you feel differently. The other thing is relaxing your shoulders, because often people, if you're tense up here, it's like you can't. It's almost like these fine motor skills are not allowed yet. They're all macro, because it's the big defensive muscles, so you can run away and punch someone that are all taut.
Right.
And actually relaxing that is also the same thing. So then you feel firmly planted, relaxed in your shoulders, and your hands are moving a bit more freely, and you don't have those coarse movements.
A bit like watching a snooker player.
Yeah, but you're absolutely right. It changes the state of the injector when they feel certain in their stance and relaxed. They're a better injector as well.
And you think, just to confirm, you think that can be done even before we gain experience? Because someone might be watching this thinking, well, it's all right for you, you've been doing it 12 years. But do you think that could be done if you make the decision?
I think it's relevant even for me, injecting 12 years on, because, if I'm running late, that can put me in an uncertain state, and I can try and lean over the patient a bit more, and it feels really different. And that's what normally triggers me, is like, just stop trying to. In fact, I'm pretty good at not rushing these days. I went through a phase of learning the hard way that there's always a negative payoff. When I say rushing, I mean having time on your mind. Time does not, people who support me will know this, time does not come into my mind, and I will sometimes run an hour late. But that's because I know that you can't get away with having your brain going even 10 minutes ahead. You need to be in the moment. And that means you need to be planted in the moment. And that's a way better way to inject. And once you make the decision, it also feels right. It's the right thing to do for your patient.
What about taking you back to the aesthetic goal? So what are you doing now at this moment? So you've got yourself stabilised and you're ready, you got your mental model. What are you going to do to make sure we get a good result injection?
That's a really good question, because that's actually the next thing that comes in after the safe. In fact, it's the bit that comes in to design the treatment plan is all about the aesthetic. Then the actual injection technique is about safety. But then as soon as you've got your injection technique right, you need to go flip back to the aesthetic goal. So the aesthetic goal is something you can work on also for years. Like you have to really. I have this theory that we all know what good aesthetics is. We know what beauty is, but we don't know on an unconscious level. So one of the goals of a good aesthetic clinician is to constantly trying to drive that to the surface. That's what I was doing with sculpting recently, trying to learn to sculpt, is that you're driving what you know on a primitive level into your conscious brain so that you know logically why it's there. And that takes years of practice. And there's a constant relationship between what you know intuitively and what you know academically.
About beauty.
And there's you're constantly thinking about that, and you get better and better and better at it. And it's, I often say to people, I didn't know what a nasolabial fold is on my first course, and I didn't know why we were treating it. It was a slight shadow on some 38-year-old. When it disappeared, I'm like, she actually looks better. And that's the first step. That's what you're doing all the time. So then once you've been doing that for long enough, you get an instinct for it. And I always say that actually women have got a head start on this, because you guys do makeup. So you're already creating beauty on your own face and getting those intuitive, the gut feeling, which you get as an injector as well. Once you've got that lined up in your mind, you know what you're aiming for. There's a sense that I get, like an itch. I know I can make this person better looking. Let me do it. And that's the next thing, which is you've kind of started from that point of view, then gone to the safety, and then the last thing as you're injecting is you're going back into that zone and waiting to see the result that you're looking for. So there's mostly it's similar. Like you get a feeling that certain amount of volume, like 0.2 mils in the nasolabial fold, is going to make a good difference. But sometimes you're just monitoring it for that aesthetic difference, and you might go a bit more, a bit less. You might take it out, have a look, and then make a decision to go back in again. And this is something that patients notice as well. I know my patients often say to me, I feel like an artwork, because they can tell that you're in the zone of the aesthetic. Obviously you're being safe, but you're constantly like looking at the light and the shade and making sure that you're getting the result that you need, checking it, and then making little adjustments if need be.
Tell me then about because you said that by stabilizing sort of this part of the body, that's fine. But then tell me about the hand. What's going to show me with the hand, the kinds of things that are going on?
Well, as I said, it's the stabilization, particularly from the elbows first. Then mostly I'm thinking about risk with most of the injection techniques. I know where I want the filler to be. And actually that's relatively, I mean, you can put, if I use the nasolabial fold example, you can put filler in the nasolabial fold in all sorts of ways that would be reasonable in terms of just purely getting product there. But in terms of safety, it massively restricts you. This is why, you don't try and put filler in across like that, because the facial artery runs across that point. So that is still the dominant force. So it's like the aesthetics tell me where I need the filler to be, and that's in 3 dimensions. Some of it's about the mechanistic component of the face, like how it moves as well. But that's more of a driving force at this point than the aesthetic, because I've already made the decision with the aesthetic before, which is we need a little bit of volume here or a little bit of angle on the cheek. So I'm actually being driven more by safety at this point. I'm trying to find the lowest risk route to put the needle in, knowing that I'm picturing that sense that it's a repetitive process I'm going to do thousands of times, and picturing the vessels that may be there, because I can't see them, unlike Dr. Master, who we interviewed. I can't ultrasound everyone at the moment, although I love that idea. So I'm taking an educated guess about the angle of entry that's most likely to minimize lifetime risk. So for example, if we talk about the tear trough, if you want to replace volume, not really the tear trough, but at the lateral lid cheek junction, if I want to add a bit of volume here, there's a way of entering here which predisposes me to basically puncturing someone's eyeball. And that's happened. We've got a case study from someone doing that on a training day, where they went in laterally and basically also caused an area of blindness. That's a risky angle of entry. I mean, I don't want to comment specifically on that case because I wasn't there, but the story is something like you're going to increase the risk, even though you might be on the right track aesthetically. Do this 100,000 times, and one day you're going to miss the bone and go straight into the eyeball. So let's choose an angle of entry where even if you go too deep, you're not going to hit something really important. So this might be one of the things that changes my angle. Is I want to place volume here. You might use a cannula as another way of doing it, but cannulas have their downside too. But assuming we're using a needle, I want to have a good reason for my angle and my depth in 3 dimensions. So for me, it's going to be safer if I'm going underneath orbicularis oculi and just touching the periosteum. I might have also felt for the little zygomatic of facial artery, which sometimes has an exit point here. And even if I can't feel it, I'll choose a position that's likely to be slightly more superior. And all of this is guiding my eventual position. And my angle of entry is so that I don't hit the eye and I don't miss the bone and go into the cheek.
So tell us about aspirating. How do you do that?
Yeah, that's a really good question, because what I've picked up, one of the reasons that some trainers advocate not aspirating is because it might cause more trauma. And this is quite possibly true the first time you ever aspirate, that it's likely to cause, for some people, because it's a bit fiddly, that you might actually stick the needle somewhere you didn't mean to and cause an extra bruise or something like that. But the main thing for me is, if you don't get over that hurdle at some point, then years go by and you're not aspirating. And like I said, with that thinking of your practice as a repetitive behavior that has risk associated with it, that's just one other way that you can reduce risk. I think it's a significant way. I've had probably hundreds of positive aspirations now. I'm pretty sure some of them were from arteries. Very sure, actually, because the blood is a different color. So I'm confident that it reduces risk. Probably the majority of people are now. There's still a bit of debate, but I think it's a bit old hat to say there's no evidence when we've all seen the positive aspirations. You do hear that. So the question is, how do you do it without effectively and sensitively without causing unnecessary trauma? So let's think about all the different ways you could aspirate and basically either cause trauma or have a meaningless aspirate. So the first thing is, let's say I was injecting the nasolabial fold. I don't normally inject like this, but for the sake of aspirating, I'm going to show you that if I place a needle in here, aspirate, then change my position even 3 millimeters, and then inject, then that aspiration was pointless. Your aspiration really only is sensitive to the point at which you aspirate, as long as you inject in that point. So, and then as soon as you move in any direction, it's no longer sensitive. Now, that doesn't mean it has zero value, because this is something else people say is, well, it only works with the first injection. Well, that's often where we put most products. So if I aspirate the alar base, come out all the way to the dermis, to just underneath the dermis, and then do a bit more, which I could always aspirate again for, and often I would, that doesn't mean the first aspiration didn't help. So we're reducing risk, but only so long as after the aspiration, we're completely stable and then you do your injection. As soon as you move a little bit, there's no point aspirating. You're not checking the spot where you're injecting. You're checking a nearby area. And when it comes to arteries, you have to be precise or there's no point. So that's the first thing, is you need to have a stable patient, stable hand. It's all back down to that stability. If all of this is locked in place, so I'm stable at my wrist, I'm stabilized my fingers, even the only bit that's moving here, I'm actually resting. In the case of a periosteal injection, you've got one more place to rest, which is on the patient's bone, basically. Sounds terrible, but it doesn't actually hurt that much. And then you aspirate. That, you can see that needle tip is not moving much at all. So that's a meaningful aspiration. Then I can inject, and I know that at the point I've aspirated, I can inject more safely than without aspirating. I can say it that way. So the other thing you need to practice is how are you actually going to aspirate. And there's lots of practice and many different ways of doing it. One of the key things I've taught this before in different videos is you need to find a way of aspirating that has a neutral vector across the syringe. And what I mean by that is, if I pull with this hand against this hand, you can see that it's going to be very hard for me to maintain complete neutrality across the syringe, because one hand is likely to be slightly stronger than the other and it will move the tip of the needle. So you want to find a way of doing it. The easiest way is with one hand. I mean, it's not actually the easiest way, but the principle is easiest to illustrate, that if I'm pulling a thumb out from these fingers, the force that is opposing the thumb is the fingers, so that the net force is zero. I can't pull my hand apart. My thumb's not going to fly off in a different direction. So this is one way, that you aspirate in a way that makes the net force across the syringe zero. So using the same hand is one way to do that. In fact, it's the way you do it with this side as well. If you're going to aspirate using your left hand and stabilize with your right hand, you still do the same thing. You push with one finger and pull with the other finger. So I don't know how well that can be seen. So I'm sure Shati can zoom up on that process. I'm actually pushing the one plastic area away and pulling with the other, so the net force across my hand is zero. And that's the key with a stable aspiration. You can see that needle tip is not moving much. I can stabilize. As soon as you do that, which is what most new injectors do, they do that, you've now got your stabilizing point is the middle of your body. It's really likely you're going to show some imperfections there and move position, and that's really frustrating. So keep it neutral. Will it cause
more bruising?
Yeah, I mean, when people first try this, if they're not doing it in a way that's neutral, they move the needle tip around. A needle tip, that means, is stabbing into different areas. So, and this is why it's probably reasonable, if you haven't got a good aspiration technique, the argument that it causes more trauma is probably true, which is why you need to understand aspiration technique first, which is all around the stability and the neutral vector across the syringe. That will give you control. The next thing I'll just say about aspirating before we move on is there's nothing to stop you aspirating more than once. And I certainly do this in more high-risk areas. So I'll use, maybe if you're doing the vermilion border over here, you know that the superior labial artery runs up in that area, and you've had an occlusion there in the past. We did this recently for the complications program with someone who had an occlusion there. We went through how can you chip away at that risk even more. So you can aspirate once at the beginning. You could do a little linear thread, and then you can stop and aspirate again, so long as you're using a filler that you know aspirates. And we've tested this. Maybe we can put that link in the bio.
Yeah, we did a aspirating test using the various different fillers. So we'll drop a link in the description.
So you know your filler aspirates, even when you've injected some filler through the cylinder of the needle. Then you can aspirate again, give it a second and do a little bit more. There's nothing to say you shouldn't aspirate 2 or 3 times. That's not 100% because you're still moving a little bit, but each time you're doing it, you're minimizing the risk of having a major portion of that needle in the superior labial artery. So aspirate multiple times. The more you aspirate, the easier and quicker it gets. I often aspirate so efficiently that you'd hardly notice it. It's a little pullback, wait a second. There's also one other thing around that, and people might find useful if they download the link, which is there is this theory that you have to aspirate at least 10 seconds or it doesn't count. That is true on the far end of some fillers. And some fillers you can aspirate for 5 hours and nothing comes back. So you need to know your filler. And some products, for example, the range we had the biggest success with was the Vicross range. I think the TSL Redensity tube are also pretty good. The thinner products tend to aspirate really well. So for those, if you're waiting 2 seconds, it's probably more than enough time. Most of them, if you see in the detail, were kind of a second or less, straight from my arm. So real blood aspirating straight back with a prime needle. So that means you don't have to wait forever, and you can do this process relatively quickly. Keep a close eye on it, and look for those tiny little speckles of blood that sometimes you get when you're partially in, and then carry on that way. And you can definitely add layers of safety, and it doesn't take forever when you practice it.
Mm-hmm. As well as the link in the description for that experiment we did, Tim did, aspirating, where Dr. Ahmed literally injected your arm, didn't he, with all the different fillers. We also have a download for you, specially to accompany this episode, which is all about Tim's top tips for great injection technique. So if you could tell us, what thing do you see injectors doing? What mistake do you see them doing the most that you think, and you kind of want to, maybe you see them on videos or whatever?
Probably one of the more subtle ones that might be worth thinking about. I wouldn't say it's always obvious. It's obvious when I've got an injector in front of me, and it's not that obvious on videos, is depth. So the difference, if you imagine injecting a vermilion border, one of the most common places people inject to enhance the lip, the difference between a safe and an unsafe depth is really hard to see on most video footage. It's a matter of 1.5 to 2 millimeters deeper. And you're suddenly in a realm where, not every time, obviously, but I'd say you're probably 100 times more likely to cause a vascular occlusion in the long arc. So, there's supposed to be 1 in 15,000 chance of doing it. So you still, what is it, 1 in 150 or 1 in whatever? My maths will probably be slightly off, but basically you're much more likely to do it by being a little bit too deep. So I would just ask yourself the question, how deep do I really need to be? Knowing that the superior labial artery and the inferior labial artery is usually, but not always, just under the orbicularis oris muscle. And that's, depending on the paper you read, it's as little as 3 millimeters. So if you Google depth of the superior labial artery, the first paper that comes up is actually saying the average is 3 millimeters. Now that's not very much, but a needle is nowhere near a millimeter thick. So you've got room with a good quality product to place it above that. Only if you're thinking that way. And I can tell when patients are thinking, or when injectors are thinking mainly about the 2 dimensions and the shape of the lip rather than where that artery might be, because they're just a little bit too deep. Tend to get more bleeding there as well. You tend to see more bleeding with those techniques. That's probably the one that I see the most that's kind of subtle, but to the trained eye is obvious. So if you'd like that download with all the aspiration times for the fillers that we tested in my arm, that's available in the link below. And you can also get a download of the summary of how to inject safely and effectively with my injection technique guide, also in the links down below. Thank you very much for watching, and we'll see you next time.
Take care.